One of the issues in medical education is that the health needs of the society are known by the society. And I like what Prof says, that probably people shouldn't go to the hospital. So the society is, in other words, saying the need is more prevention than curative. So that's part of the way curriculums are designed. Know the needs of the society first. And so the goal of health system is to respond to the health needs of the society, the goal of any health system. And you know, when in health professional education, we are training people to meet those health needs. And so those health needs for the society is like the goals of the curriculum for any health profession comes from the society and not necessarily from the institution. I think that is one of the key things. So the other issues about health is the issues of quality of health. That should be evidence-based, patient-centered, and given in a timely fashion. And of course, in our day and age, there are issues of equity in health, reducing risk, promoting healthy lifestyles, and responding to underlying determinants of health. Those are the main issues in health that should be looked at to ensure that the issues that we are talking about, equity in health, looking at the social determinant of health, talking about reduction of health risk, are taken care of, so that the health industry, the students are helped to meet the needs of health in the society. Of course, the pillars of medical education includes curriculum, instruction models, institutional designs, assessment. Institutional designs as in where is it taught? Because majority of the times, the teaching of medical education has been in hospital-based. But of course, like we're being told, we've been challenged here by Prof. There is a change to see that that teaching also takes place within the community as well. So over the years, there has been, if you read the literature in curriculum development for health professional education, there have been like 3 generations of them. The first one that was brought about by a research or a project carried out by the Carnegie Foundation through a gentleman called Abraham Flexner in 1910, made the first major curriculum in health professional education, of course mainly for the physicians. That was scientifically based curriculum. And you know, the scientific based curriculum was the one that now we call the traditional curriculum. If in medical education, if you talk about traditional curriculum, is the scientific model where the students were supposed to learn basic sciences before they go to do the clinical studies, as we do it right now. The issue with that curriculum is that majority of the time, as we are told, it is information-based. It is lecturer-based. In other words, the lecturer is the one that has the information, and the student gather around the lecturer to get that information. And so it's a university-based curriculum, done mostly by majority of the universities. The second generation that came later on, I think in the 60s going to 70s. It's a problem-based curriculum. I think started in Canada, McMaster, and then continue. I think we have a bit of it that came in Kenya in Moi University that wanted to do that. Of course, I think majority of the time it was taught by people who came from where I come from, which is traditional. So there's a bit of mix, but there is problem-based curriculum, which was mainly taught from, if you look at the developed countries, mainly taught from teaching hospitals or academic centers that had hospitals as it is. So problem-based learning basically means there is a horizontal integration of basic sciences to clinical problems. So instead of teaching students like in class, majority of the time the students would be taught in small groups that discusses their clinical problem, right from the issues of anatomy, physiology, pathology, microbiology, and all the way to the clinical application. And I think the idea there was, when you meet patients, as much as you want to know the anatomy, the issue is the patient has a problem that needs to be solved. And so you teach the skills of problem solution or clinical problem solution to that particular students. And then the last one that came in 2000, as we go on, there is the old discussion about competency-based curriculum. In other words, you look at, so what do we need a doctor to be competent in? So number one, we need them to be competent in talking to patients, like taking history, a good history, taking skills, good physical examination. They need to know how to probably deliver bad news to patients, and so you look at those skills in terms of what do we need the doctor to be good in. And then I think related to that are the issues of that we're being told here by Prof. That there is the increasing non-communicable disease, chronic diseases that are in the society, and patients come with cancer and they have other chronic diseases, and they are okay. So they need like interprofessional discussions for their management. And so how do we help the people that will come from our universities to have the idea of interprofessional education, or know how to work in a team with other professionals and discuss patients with them in order to get proper health outcomes. And so if you look at the curriculum, maybe the picture is not that figure is not well, not very clear from the back, I'm sure. But at the top is the objectives of the curriculum. At the bottom is assessment. On the sides are the teaching methods, and then the content, and you have the educational outcomes right in the middle. So if you want to look at the curriculum, that would be, how do we design a curriculum that ensures there is cognitive, psychomotor, and affective knowledge for our students, and design the contents for various levels of training. So the key issues that we will discuss are those 6: interprofessional education as an issue that is coming up, that our curriculum should be able to look at. So how are patients really managed? Because we know that patients are managed in professional, with various professionals. So you go in the ward, there will be a nurse, there will be a physician there, and probably, like I was saying, if the patient has other diseases, there will be other people coming. For those of us in the oncology space, that you know you will need a surgeon, whether that is a gynecologic or surgeon or just surgeon with others from other specialties. You will need a radiologist, a radiologist, an oncologist as well. So how do you manage patients as a team? And then the issues of competency-based education, longitudinal integrated clinical education, education in the social determinants of health, and continuum of health profession for lifelong learning, and the issues of technology. So interprofessional education, like I said, the patients come with complex diagnoses with other conditions. And if you are talking about oncology, that is the main issue now, you need a number of professionals that include nurses, physiotherapists, and all those other teams. And there is evidence that indicates that highly functioning collaborating teams leads to better health outcomes. And so there are a number of universities that are now beginning to implement interprofessional education programs to train health professionals to work effectively as part of the team. I think for us in the University of Nairobi, we have had this discussion probably now for 3 years, going to 4. We have had a discussion with the University of Washington. I think we did a visit to them late last year, just looking at how do we then begin to think about interprofessional education. In what areas do we see that working, and how can we start interesting students in the pre-licensure place? That means the undergraduates, teaching maybe the pharmacists together with the nurses, together with the doctors. What is common in those areas, and how can we help? Of course, it is important to know that stronger unidiscipline leads to stronger interdiscipline training. But what are the common areas that we can work on together? And I think that's part of what took us to University of Washington to just see how they do it. I think for that to be successfully implemented, of course, there must be leadership. There must be some planning. And when we do engage the learners, they should be engaged in something that is meaningful to them in the advance of their professional development. Technology can sometimes help, especially if you want to do simulation-based learning. Of course, faculty will have to be helped to know how to run these things in the interprofessional development. Of course, the challenges would be challenges of space, organizing that, and of course, issues of culture of each profession. We all want to just be what we are, doctors, nurses separately, and pharmacists separately. Of course, there is the elephant in the room of political dominance of the physicians. And of course, majority of the time, we may not see the urgency in it. But, like I was saying, it has been shown that where the teams function optimally, there will be better health outcomes, there will be better patient experience, and it will lower the cost because everybody is in the room. When you think about the competency-based education, of course, the idea for us who are physicians, of course, we have the responsibility to the society to produce practitioners who are competent across board, of course, mainly in the issues of knowledge, attitude, and skills. The only issue is, like, you know, initially medicine in Kenya was 5 years when we have the A levels mainly. I think when 844 came in, then we went to 6 years, and so the assumption was at the end of 6 years the individual should be competent. So time was used as a proxy for competency. But I think the idea here is time should not be the standard for competency. The competency should be something that the supervisor assess and know that this individual is able to do one or two things that are required for a doctor to do. So the needs of the contemporary society to improve healthcare. So like I was saying, that we need to ensure that by the time somebody is released to the society, they are able to do history, they are able to take history of the patient, make diagnosis, and make plans for treatment, and not just because they have taken 6 years. Of course, at the end of the year, at the end of the day, majority of the times, the competency comes within those 6 years. Because of course, the years are, year one, we need you to have learned this particular competency, you've learned this, and next year we need you to have learned this. And so over time, you accumulate those competency, and majority of the time, by the time somebody takes 6 years, they're able to do what they are required to do. But I think the emphasis of competency-based is that the two should be separate. So the time is a resource and not just that you took 5 years so you are competent. I think the issue is to allow adequate time so that the students achieves their educational goals, but also to afford the teachers the time to observe, make their assessment, coach the particular students so that they are comfortable with their judgment, so that when they are released to the community, the community would be safe in their hands. Of course, the challenges in terms of competency-based curriculum would be the setting of that curriculum itself and the faculty developments, regulatory changes that will permit greater flexibility so that an individual that gets those competency without necessarily hitting the time can also be given opportunity to be released and be certified, and of course assessment system to evaluate those outcomes as well. The idea of continuity of care is a concept that is being emphasized, and the continuity of care here in terms of integrating in clinical education is about the idea that if you look at the current environment, we have a situation where majority of places where we teach medical students or nurses are hospitals. And it is because the hospitals is where you get the teaching material, who is the patient. And majority of the time, those patients are sometimes the most sick patients, are the ones that are in the hospitals. And sometimes they require intensive care. And sometimes, because of the nature of that illness, they may not be the best opportunity for learning for the students in terms of learning the natural history of the disease, as it were. And so there is suggestion that is coming in that for continuity of care in terms of care of the patients beyond the hospital, there needs to be a situation where the learning site is not just the hospital, but the community as well. And so you don't have just the rotations within the hospital, but these rotations needs to be within the community as well. So you use community hospital as well as the outpatient setting, so that the person who comes out is competent enough to deal with the patients who are in the community, or following up patients with chronic illnesses, which is what we are having to deal with currently. And when you do that, then it permits horizontal integration as well as vertical integration. And there have been studies that have compared the traditional method that I was saying to this particular method, where there is community component. The idea is that in terms of knowledge and clinical skill acquisition, there is no difference. But in terms of satisfaction and confidence and patient-centeredness, the people who then involve the community and outpatient basis of site of teaching have great higher confidence, and they have stronger sense of patient-centeredness. Of course, when we do that, then it gives the opportunity for the interprofessional education. It helps the students learn the impact of illness on patients and social determinants of health. And then the relationship between the learner and faculty in terms of feedback is developed. That greater satisfaction reduces burnout and help the candidates in terms of just developing the lifelong learning. And of course, it reduces the number of students, because I think for us in University of Nairobi, we struggle with the numbers within the hospital. Right? It reduces the number of personnel in the hospital. Of course, the challenges would be the infrastructure to support that in terms of infrastructure to support teaching in the communities. Economic pressure for productivity, because every time you see a patient in outpatient, you want to see many. Of course, we also have these issues of you want to see students in the hospital, and of course, the incentive for teachings are also low. The other idea that has also come in terms of health professional education is the whole idea of community health or public health focus with education in social determinants of health. And also the idea that, like Prof was saying, humanizing health care. Because we interact with human beings most of all at their most vulnerable point. And because of the nature of human beings, it is very possible to just look at them as material, as we were saying. And so social determinants of health are important because they contribute, major contributors to the health of the society. There will be the principal causes of health disparities or inequalities that we find in our society. And so the whole idea is to say, what are these causes of health inequalities within a society, for example? Why are some areas not served as well as others? And is it something that can be taught in health professionals as doctors learn, so that they have in their mind how to handle such kind of inequalities. Because I think the idea is to have not just informative or formative education, but a transformative education, where every health personnel has the ability to take leadership in the spaces where they are, so that the spaces where they will be, they will realize the changes that will help improve the health outcomes. And so the issues of interprofessional learning, transprofessional learning goes beyond the space of the healthcare, so that you interact with the with the engineers to design systems that work for you. You interact with the people of water that deal with the water to ensure that the diseases that are caused by water are handled by either lack of water or dirty water. Those are handled by the people who deal with water. So how does an individual health professional deal with other sectors that are outside health to ensure that there are better health outcomes for the society? I think those are the ideas that are coming. How do we include those in our curriculum so that the product that we have is not just, for lack of a better word, not just your traditional doctor, but a transformative leader in the healthcare space. Like I was saying, we need to have the human face or human interest and values and put dignity at the center of focus in terms of learning. So I think the idea is, how do we include that in the curriculum? How can we teach that in the curriculum? So that we combine the scientific and the humanistic heritage that we have. Of course, there is this idea that we have a social contract with the society, and that is why majority of the time the healthcare professions take an oath. That particular oath is the Hippocratic oath is, of course, the main idea is that you are having, you are taking a solemn vow to the society. So you have a responsibility to the society. And that social contract with the society needs to take care of what the society needs in a transformative manner, where the space where you are, you need to ensure that the society gets the best of healthcare that they have. Like we have in Kenya, the constitution says they have the right to the highest level of healthcare. So how do we produce doctors that ensures that the society have the highest level of healthcare and that we are responsible for that? There is also the idea of continuous education, health learning, right from undergraduates to postgraduates. I think in our society there has been, if you look at the developed countries, especially the US and I think South Korea as well, majority of the time there are very few people who can finish undergraduates and practice on their own. I think we do it because of lack of doctors. But in that space, there may be more doctors. So I think the issue is, as we continue to produce more doctors, right now we have a number of them who are not employed. Is it probably time to rethink the way we deal with our curriculum, to think about the continuum of health education? Because education, there is, I know that 60 years do final exam, but really there is no final exam, because there's continuous education. How do we ensure that every person who gets into health profession space understand that idea that it is a lifelong learning, because scientific developments in terms of evidence of management changes every other few years. How do we ensure that the people who come for in the healthcare space understand that, and so that there will be that idea of continuous learning? And how do we ensure that that is put in issues like regulatory bodies, so that it is something that is planned for and instilled? If you look at the learning environment for the doctors, again, it is is something that consists, of course, of personal perspective from the learner. What does the learner think? What do they feel? How do they see, for example, University of Nairobi, or Maseno University, or Moi University? How does the community in which the teaching and learning occur, what is the organizational culture, and what is the physical space? How is the well-being of the learner being taken care of? How do we empower the learner to feel that they are doing meaningful work, and increasingly over the year from year 1 to year 2, that they get responsibility that is appropriate to what they have learned in terms of the care of the patients. And I think so those are the things that probably we need to be thinking as we develop the environment, and those are the trends that are coming, that the learners, I think there's some things called EPA, which is entrusted professional activities. What are the activities that the learner can undertake without necessarily being supervised as they go through the years? When it comes to technology, which is changing every aspect of our life in a very accelerated manner, there have been ways in which technology has helped medical education. One of the ways that I know, of course, is simulation-based learning. Simulation-based learning helps in terms of skill development. So instead of you doing your intravenous line on a patient first like we did, these days it is possible to have a skills lab where the learner learns to perform some of this activity on a simulated patient, so that by the time they go to learn to patients, they actually know how to fix those lines. There are simulators that can really simulate a real patient, and so they can help learners learn clinical reasoning. And where there are teams like these, people who are in critical care space, or people who work in theater, there is a way in which simulation can be used to help you communicate with one another better in terms of teamwork. And so that is a way in which technology can come, or has come, into the space of learning. Of course, we know that there is online learning that gives more time for reasoning. So there is an idea of flipped classroom, where the learners have the material. I think in our space they're called asynchronous learning, where the materials are online, the learners can go there anytime and learn them, and then you have time with them. Flipped classroom, where you have a small group who have already gone through the material, so they just come for discussion for you to understand as a teacher, understand what have you learned, what gaps still exist, that that particular interaction with you can help them narrow that gap. So flipped classroom. And of course we know there are online certificate courses, including an online certificate course on medical education, I think run by Michigan University. So I know that majority of people that think that AI will replace doctors in future. Probably may not happen. But I think a successful doctor in future may be the one who knows how to manipulate AI for clinical care and education. So that if I know how to work with AI to care for patients, or undertake education, then you will be the most successful person. The future doctor also need to know data and how to interact with data, and the limitations of any majority of the database, because AI works with algorithms, And it is good to understand that some of those algorithms may be based on a biased data already. And so the future doctor is one who would want to understand those algorithms and how they are made, so that you know there could be biases even in those algorithms. And of course, as I say, will be one who understands the limitation, the use and limitation of telemedicine for learners and faculty. And I think that is something that we must learn. And of course, like in Kenya, you know, we have an act for a digital health records act that will probably force majority of us to learn how to use EMRs. And it is important to know the use and limitations of EMR. And I'm just saying, these are things that I think should be included in the curriculum, because there are things that are affecting the society. And so how do we include them in the curriculum so that the doctors that we produce are doctors who work well and who meet the health needs of the society? In terms of accreditation, I think not so long ago, the accrediting bodies are forming. I think in Africa there is AMCOA that is forming. I think they had a meeting, the worldwide meeting of people who do accreditation. And I think accreditation is an essential ingredient for any system in health professional education. So that they are essentially, accreditation is the health profession. In the health profession is a process where there is an evaluation of an educational program or institution against defined standard. So you have by an external body. So they say you should have one student, one faculty to 7 students for quality purposes. They say you should be able to have a radiology department, a pathology department, in order for you to train a good doctor, for the doctor to understand what is happening. So they look at that and say, how are you meeting that? And accreditation, of course, contributes to the high quality training for a competent workforce. Accreditation can be mandated either by the government or a professional body. I think in our country it is more of the government. Of course, professional bodies want to get into that place. Funding for now, I think, is a mixture for majority of medical schools. There's a way in which I think they contribute to the funding of that regulatory scheme. And regulation can either be a quality assurance or improvement, depending on what is the question. I think sometimes in our environment is more quality assurance, more summative than formative. But I also know that there are a lot of formative feedback that are given to the universities, having worked with the council, so that they strengthen the existing curriculum or existing educational programs by the various universities. And so accreditation contributes to the educational process right from pre-admission to improving the health outcomes, as it were. When it comes to assessment, of course, majority of the time, that should be aligned with the program goal. In other words, anytime you do assessment, you should be looking at, so what are the learning outcomes as pronounced by our curriculum, and assess students based on the learning outcomes of the curriculum. And of course, if you look at your curriculum, there will be year 1, what are our goals, year 2, what are our goals, and the students should be assessed based on those particular goals. And there should be a balance. I think there is more movements in terms of assessment for learning, so that assessment is more formative than a summative assessment. assessment for learning, so that it's more of the feedback bit in the process of learning. And of course, we have work-based assessment. I think that the main idea in terms of evolution of trends in assessment is to have more data, so that the assessment is not a one-time assessment. You have more points where you accumulate data, so that by the time you say this particular person is competent, it is not one thing. You just didn't see the patient, the candidate clerk one patient. They have clerked a number of patients from different systems. They have interacted not only with one person, but with many people. So that particular form of assessment, in terms of multiple points of data, is probably what the trends in assessment is. The other issue is going away from the numerical rating. I know one of the difficult things in the university is that the university wants the mark, right? But I think there is a movement towards more narrative data in terms of assessment. Is this student competent or not, rather than saying the student has 50% or 30%. So I think there's movement towards meaningful narrative data. Because I think it has been found to be a better assessment in terms of competencies for complex tasks, including component of humanism and professionalism, because sometimes it's difficult to say professionally you are 50%. And so if you look at the summary of evolution, the new innovative curriculums, you can have eponym. I think it's eponym. Spices. If you look at your right hand side, it's spices. Away from the one that is teacher center, information gathering, discipline based, hospital based, standard program. I hope I have given time for discussion. That's what I wanted. Well, I just used my time to give you time so that we talk in this space. But I'm just saying, in terms of evolution, the newer ideas in curriculum is SPICES, which is smaller group, interactive, student-centered learning, problem or team-based methods, where clinical placement is now in the community, utilizing non-hospital in community setting, and then the issues of accreditation and assessment with multiple data points, narrative-based, which leads to a transformative learning, self-reflection, critical thinking, patient-centered, lifelong learning, interprofessional collaboration, and social accountability. That's what I wanted to say.